Thank you, Celso. Thank you also to the organization for the invitation to be here. So I was told by the other co-chair that he will do a much nicer introduction.
Let me say right now. So we're wondering what's the connection. Can you hear me? What's the connection between breast and eyes? We thought both are a pair and both are critical for vision.
So, sorry, Celso, but I prefer that one. So, besides that connection, I don't think there is many more. No, there is. We were discussing a case that I have now of a lady with a particular subtype of breast cancer that it's called lobular, that gives metastases in everything that you can imagine and has a metastasis in the orbit. And I've seen another 1 or 2 cases in my career of metastases around the eye in several places of this form of breast cancer. It's not very frequently, but it can happen. So my role today is to guide you a little bit through what we have been doing in the field of breast cancer with the use of genomics. These are my disclosures. I have also to disclose that I'm the PI of one of the studies with one of the genomic signatures, but I have no financial interests in the mama print, which is the genomic signature involved in the study. So the problem is the following. So in breast cancer, when diagnosed early, we have a very high rate of cure. And what has happened for many decades is that because we only have one opportunity to cure or to give a very long survival, we tended to overtreat because in doubt regarding the risk, we would tend to give chemotherapy. And this has been like that for a long period of time. And obviously, we would like to decide on those who need chemotherapy and provide the chemotherapy only for those early breast cancer patients and not for all of them. And obviously, when we choose from all breast cancer patients that need adjuvant chemotherapy, we would like to identify those who could derive benefit, hopefully without toxicity or minimal toxicity, but even if with toxicity, at least that they derive benefit. And we want to exclude those who do not derive any benefit from the treatment. The second reason is also a financial reason. And this is like that in every area of oncology, but it's particularly important for a cancer that is the most frequent cancer of all, which is breast cancer. And therefore, the economic burden of treating breast cancer has been increasing with the development of new treatments, particularly new treatments in the adjuvant setting. So this, what we call financial toxicity of our treatments, is also a reason to select better the patients who need treatment. Now, how do we do this selection of patients or individualization? We need to answer 2 questions. Who needs the treatment, and what is the best treatment for the individual patient? So, meaning we need better prognostic factors and better predictive factors. We have been very good in breast cancer with prognostic biomarkers. We have not been that good with predictive biomarkers. Now, another important notion that I wanted to leave so that you can understand the rest of my talk is when we're talking about clinical implementation of a biomarker, there are 3 parts that are critical. One is the analytical validation, meaning that we have to have a good test that is robust, reproducible, and that we can trust. The second is the clinical validation. So we need to look if that test is correlated either with a risk or with a classifier or a clinical state or an outcome, but it has to have some clinical meaning. And then the third one, which is the most difficult one to prove, is the clinical utility, meaning that if we can use the test to identify either a prognosis or a better response to a certain treatment, that actually results in a benefit for the patient. How do we traditionally decide when to give chemotherapy after surgery for breast cancer. These are our traditional factors that are extremely important and that we use all the time in our clinical practice. So tumor size, lymph node status, particularly the axillary lymph node status, grade, and the expression of 3 biomarkers that are crucial: estrogen, progesterone receptor, and HER2 receptor, and also the presence of lymphovascular invasion. And what we can do is use them individually, but there are also tools to help them put all these factors and several others together. Some of them are these algorithms, the ones that exist and are more frequently used are there: PREDICTIVE, Adjuvant Online, and Nottingham Prognostic Index. But we can also do that by developing guidelines and helping to choose the treatment correctly for the different groups of patients. As I told you, in terms of predictive biomarkers, we have not been very successful. And despite decades of research and a lot of investment, we only have validated only 2 predictive markers. One are the estrogen and progesterone receptors, and they are predictive for response to endocrine therapy. And the other one is HER2, and is predictive to response to anti-HER2 therapy. And that's all I'm going to say about prediction, also because of lack of time. So focusing now in terms of what have we done in terms of prognosis. As I think you also know, breast cancer has been leading the field of genomics for a long time, until maybe the last 3-4 years with the development of immunotherapy that has been more important in other types of cancer. And everybody's making fun of us now and say, see, you're not always on the top leading role. And it's true, we are not in the top leading role in immunotherapy. But in terms of genomics, we were one of the first cancers that used genomics to reclassify breast cancer. And we developed what was called the molecular subtypes. And for lack of time, I'm not going to go into the details, but just to tell you that these subtypes, and we can say that there are 4 major subtypes in breast cancer. One that it's called the triple negative, who has none of those 3 biomarkers that I told you and has the worst outcome. We have the HER2 enriched that has average outcome. Actually, with treatment, it has one of the best outcomes, but without treatment, it is one of the most aggressive. And then we have 2 that we call luminal, that are the ER positive. One is luminal A, and the other one is luminal B. Luminal A being more indolent cancer, and luminal B a more aggressive, highly proliferative cancer. Now, genomics have been extremely useful in the understanding of biology, but in terms of clinical application, it has been difficult for logistic and financial issues. So what we have done also was to develop what we call surrogates. So with the use of traditional pathology, how can we approximately classify as well all patients in these 4 major subtypes? And this is how we do it. We use ER, PR, HER2, the grade, and the proliferation marker called Ki67. And then we classify. So do we lose the prognostic value if we use the surrogates? No, the surrogates also have prognostic value that you can see here. So the different subtypes defined by the surrogates also have an important prognostic value. They are not 100% equivalent to the molecular. They have some shortcomings, but they can be used in our current clinical practice. And they also show us the crucial role that high-quality pathology has on everything we do in oncology. And also, obviously, is cost-effective, because pathology is not that expensive, and it's crucial for all the determination and all the treatment that we do. Now, because we understood that we were over-treating, and with the current clinical pathological criteria, we were over-treating patients. This is how the development of the genomic signatures started. And they started quite a long time ago, in the beginning of the 2000s. These are some of the genomic signatures that exist. I am going to focus mostly on 2 of them that have the highest level of evidence, which are MammaPrint and Oncotype. And they are also very often called the first generation signatures, not just because they were the first to be developed, but because they have some characteristics such as being better in defining those patients who have a risk of early relapse. And I'll show you why for us in breast cancer is also important the late relapses. So the first one is called Oncotype DX or Recurrence score. Not going into a lot of details, this is a signature of several genes that are related to the estrogen pathway, the HER2 pathway, and the proliferation, a little bit less with invasion. They are put together also with reference genes, and we are provided with a score that is a continuum score, but has been divided in 3 groups, low, intermediate, and high risk. This test was developed in luminal cancer under treatment with tamoxifen, which is the most commonly used drug in the adjuvant setting. Now, it was first developed in node-negative breast cancer, and what it shows here in this graphic is that those who have a high recurrence score derive a bigger absolute benefit from chemotherapy. And those who have a low recurrence score, the benefit of chemotherapy is not that we can say does not exist, but it's very small and it doesn't compensate for the side effects. Now, later, we have also tried to validate Oncotype in node positive. It also works, but perhaps a little bit less efficacious than for node negative. There are some discussions about can we use these tests also as predictive, but the only thing I'm going to tell you, not to complicate too much, is that all these signatures, particularly the first generation signatures, identify high proliferative tumors, and high proliferative tumors respond better to chemotherapy. But they do not allow us to choose between the different regimens of chemotherapy that we have. Now, Oncotype was validated in a very large trial. So this is the trial called TAILORx. It enrolled or screened more than 10,000 patients to randomize 6,700, and mostly it was done to give us 2 informations. What should we do in the intermediate score? Because it is apparent from the previous validation that the low risk can be treated with endocrine therapy alone, and that the high risk needs chemotherapy, but what do we do with the intermediate score? Now, the first time that TAILORx were presented were mostly to present the low risk arm, and you can see here that no matter which outcome we choose, at 5 years, we have excellent outcome with endocrine therapy alone, confirming that if a patient has a low risk score, we can avoid chemotherapy. And this would be independent of tumor size, of age, and grade. And this is important, of course. Now, this year at ASCO, the results of the intermediate score were presented. And again, to make a long story short, you cannot separate the curves, right? So there is no benefit for chemotherapy also, or not significant benefit for chemotherapy in the intermediate score as well. So now what we can say is that if you have a low score, you have a 3% risk of distant recurrence with endocrine therapy alone, which is something we have to discuss with the patient, but most patients would not go for chemotherapy because of this risk. If you have an intermediate score, that risk is 5%, but if you do or do not do chemotherapy, you only get a difference of less than 1%. So the question is, for every patient, do you want to get chemotherapy for less than 1% benefit? And then, I know you're looking at me, Bettina, but I have some patients who want chemotherapy for less than 1% benefit. But most of them don't. High risk, despite chemotherapy and endocrine therapy, they do have a 13% risk of distant recurrence. So not always is chemotherapy the answer for the higher risk. Now, this test is also being validated in other trials. This is a German trial that looks confusing, but it is not. In the luminal part, depending on the score, the low score the low score receive only endocrine therapy, and the intermediate and high score were randomized between two types of chemotherapy. I'm going to skip many of the questions that this trial was trying to answer and show you just the prognostic impact of the test. And what you can see here is that the test, the prognostic impact was clearly shown both in node negative and node positive, with the high recurrence score having a much worse outcome than the low and the intermediate. And in this trial, we could potentially save 18% of patients from chemotherapy. What we also saw in this trial was that if we use the marker of proliferation called Ki67 in a centralized, experienced lab, we actually have a very good correlation. The problem with this marker is that he is not very reproducible, and we need to have a high-quality pathology lab to be able to use it. I'm going to skip a little bit more this because of time, because I want to explain to you the other test, the one I've been involved in the development. So this test is called MammaPrint. There are some differences regarding Oncotype. This test was developed, in ER positive and ER negative untreated patients, so patients who had had only surgery. And what you can see is that these 70 genes are able to divide or separate a breast cancer population into one that has an excellent survival with 96% of survival at 10 years without adjuvant systemic treatment, and a population who has a very poor prognosis with 50-50 chances of survival if you do not give adjuvant chemotherapy. Now, what did we do? The first thing we did was an independent validation of these findings at an European level. We did this in about, I think, 7 countries. We collected 300 samples and independently run the test and had the statisticians evaluate it. And we were able to confirm that the test had prognostic impact and allow us to isolate those who had a very good prognosis without need of adjuvant chemotherapy. Then we moved on to try to validate it in the node positive, and yes, we can do it, particularly for those who have only until 3 positive nodes, who are considered an intermediate group, and we can split almost the same way this population. We also see that the high risk responds better to chemotherapy, but as I told you, I have a lot of problems saying that this means that they are predictive because of the reasons I already explained to you. Then MammaPrint had the first prospective trial. This was a non-randomized prospective trial that was run in one country alone, the Netherlands, and showed that the MammaPrint low risk without chemotherapy had a 10 years distant relapse-free survival of almost 94%. So proving that really those who are identified by the test can not be treated with chemotherapy. And so we moved to the large randomized trial, and I know that it looks complicated, and it is a little bit, but I'll guide you through it. So we randomized we enrolled 6,600 patients, and what we did is we evaluated the risk of relapse using the traditional factors and using the genomic tool. And 3 possibilities would arrive. Both would say that the risk was high, and there we would just assign the patient to chemotherapy. Both would say that the risk is low, and we would assign it to no chemotherapy, just endocrine therapy. If they were discordant, we need to know which one is right. And so we randomized to follow the clinical risk or follow the genomic risk, okay? There are other randomizations, but I'll not speak about that today. So we enrolled all these patients in 111 centers in 9 European countries. At the time, we needed to collect frozen material and have the results on an actual, in about 1 week time, which made this trial quite challenging. Now, the primary endpoint, I'll take a few seconds to explain to you. This is a de-escalation trial, so treating less. And to do that, you have two possibilities. You do a non-inferiority trial, and if you do a non-inferiority trial, you usually need 12,000, 15,000, 20,000 patients, which are totally unfeasible in terms of logistics and finances. Or you define a threshold that you want to achieve. And we defined the threshold and said that for those patients who traditionally would be high risk for the clinical factors, but the genomic test would say low risk, and we would do what the genomics test says and would not treat with chemotherapy, that those patients would have a sufficiently high survival, and we defined that as a distant metastasis-free survival of at least 92% at 5 years. So the results, first of all, the proof of the prognostic value. You can see here that the discordant cases are intermediate prognosis. The ones who are high risk by both methods are the worst prognosis, and the ones who are low risk are have the better prognosis. And then the primary test, what we observed for that group of patients was 95% of distant metastasis-free survival, clearly passing the 92% and making this a positive trial. When we looked as a secondary endpoint on the role of chemotherapy, what we saw is that the maximum benefit that we could see would be between 1% and 1.5% of the benefit of chemotherapy in that group of patients. Again, we have to discuss that with the patient, but the vast majority of patients would not do chemotherapy for such a small benefit. So we concluded that this trial provides the highest level of evidence for the clinical utility of the test. This was independent of node positivity and also of grade. And I did not show you for lack of time, but in the trial, we had 14% less chemotherapy prescribed. And if we would apply to all clinical high-risk patients, we could have a 46% reduction in the chemotherapy prescription. So what do we do now is when we have a luminal cancer, we define traditionally low risk. And if it's traditionally low risk, we just treat with endocrine therapy. If it's traditional high risk, we discuss with the patient if she would receive chemotherapy for a 1.5% benefit. If she says, I'm going to have chemotherapy even for 1%, then we don't do the test and we go for chemotherapy. But if she says, no, that's not sufficient for me, I need a higher risk, then we do the test and we decide according to the result of the test. What this trial has also allowed to us was to have a gold mine of biological material. We collected frozen, paraffin, blood and serum from all the 6,600 patients, and a lot of research is being currently done using these samples. Now, I want to show you two things before I stop with regarding the MINDACT study. I showed you that the trial showed that we could eventually spare 40% of patients from adjuvant chemotherapy, and yet not everybody is having this test. Why? There is the cost of the test, the fact that it's not reimbursed in the vast majority of countries. There are the logistics of doing the test and the time you have to wait to have the results. And if we look clearly to what happened, we went from 2002 with a paper in Nature and New England to 2016, another paper in New England, but in the middle there were 14 years, about 50 million euros, over 1,100 patients screened and 6,600 enrolled. This to show you that we cannot do this for every single biomarker. And this is the challenge of translational research, is how can we do things with the same level of evidence, but faster, because clearly we cannot do this for all biomarkers. And because my time is reaching the end, I'm going to skip through the rest. Just to show you here what I told you, these tests are very good for relapses in the first 5 years, but it's also what matters for chemotherapy. Chemotherapy can decrease the risk of early recurrence, not late recurrence. And the second generation signatures are the ones I don't have the time to go through, but what they did was to add to the genomic signature some important clinical parameters, particularly the tumor size and the nodal status, and they have a kind of combined score. And by doing that, they are important not just for the first 5 years, but the 10-year period. And they allow us to look not just for early relapses, but also late relapses. And this is, for example, the ProSigna or PAM50 and the EndoPredict, two signatures that allow us to look also at late relapses. And particularly this one, that is called Breast Cancer Index, is even stronger in the relapses that occur between years 5 and 10. Now, why is that important? There was very recently published also in the New England a study that, or our data that shows you what happens 20 years after diagnosis. And if you see that, and also the editorial we wrote in Nature, you will see that the risk even of small tumors, so let's take here a T1 stage, at 10, 15, and 20 years, look at the risk of relapse that still exists. So a woman, which are mostly our patients, 1% men, but they can relapse 20 years, 25 years after. And we need tests that help us identify those who tend to recur later so that we can extend the duration of endocrine therapy. So some confusion in the field come from the fact that we should not use these tests in isolation. We need to use these tests together with the traditional factors. And there was a huge fight in the beginning saying molecular biology is going to replace pathology, which is clearly not the case. They must be used integrated. And the tests do not classify always the same patient the same way. And this has also created some confusion. Final words about cost effectiveness. We have done a lot of cost effectiveness studies because we wanted to convince the payers that it's worthwhile to pay for these tests. And what I can show you in a very summarized way is all the studies that were done show that both Oncotype and MammaPrint are highly cost effective. And if we would calculate how much money we would save, look at what we would have as budget impact in the UK, in the Netherlands, and in the United States. A huge amount of money would be saved. So ask me why they are not used, and that's something I cannot answer. So finally, to show you that using technical validation, clinical validation, the genomic tools have reached both. And I've also showed you the clinical utility of the tests. And today, in our decision, we use all these factors together. And we also remind ourselves that chemotherapy sensitivity is a continuum. There is never 0% and never 100%. And how do we decide in the end? According to what the patient prefers. So we have two books, the staging book and the molecular biology book. Thank you very much.